Hey, Sarah, how's it going?
Hi, Charlie.
How's your week going?
It's going pretty well. Glad to be back.
So you're excited for part 2 of the Neal Dickert Research Ride podcast?
I am. I enjoyed learning about his research in the last one.
Yeah, as our listeners might recall, he discussed his work with understanding the process and intricacies of informed consent for participation in clinical trials.
And we encourage everyone to go back and check out part 1 if you haven't already done so.
Definitely check out part 1. So in part 2, he's going to discuss more about the other side of his research, which is related, but deals more with sort of the clinical implications of financial toxicity of medications and shared decision-making for physician recommendations.
Very important stuff.
Very interesting stuff.
Let's jump in.
I wanted to segue a little bit into the financial toxicity aspect of your work, which is a term that I heard you used in a talk.
Yeah.
And obviously it's related to this, what we've been discussing, but I wanted you to sort of broaden that.
Yeah, this is an issue we've been interested in for a little while, and we have a grant that's been going on for the last 4 years, sort of focused on this issue, specifically in the heart failure context. But the term financial toxicity is one I like. I think, out-of-pocket expenses are a really significant issue for a large portion of our population. They're appreciable for people who don't necessarily have financial constraints, but there's certainly a big hit on people who really are working within significant financial constraints. And the concept, I think, is really simple, but, financial toxicity is intentionally trying to link financial impacts to, it treats it like a side effect, right? We think about, something might make you pee all the time. That's a side effect. That's a type of toxicity, right? So if something makes you, have to spend a lot of money, that can have side effects too. And I think, so what we're really interested in, this came about in the context of heart failure. There's sort of different levels of this, but heart failure about 6 or 7 years ago went from being a condition where the sort of mainstay of therapy were all drugs you could get for $5 a month or less. So finances weren't really the barrier for that, to, new drugs like sacubitril valsartan, and then in recent years, the SGLT2 inhibitors and other things kind of coming down the pike that are non-generic, that have appreciable, but at the same time, marginal impacts on morbidity, important morbidity and mortality, but also had significant out-of-pocket costs for a lot of patients. And so, because I've been interested in this concept of shared decision-making for a long time, we thought, look, this is the kind of thing that, doctors and patients ought to be making these decisions together. If I'm taking care of a patient, I don't know what, $100 a month means to that patient. And, if you look at sacubitril valsartan, where you had, based on the best, the early study, 2 to 3% improvement in mortality over a 2-year period, is $100 a month worth it to get that benefit? Well, for some people it might be, and for other people it might not be. If it means that someone with heart failure isn't able to, enjoy important aspects of their lives, that's a problem. If it means that they then can't afford other medical things that they need, that's a problem. And so we got really interested in studying this and thinking about cost as making this what's called a preference-sensitive decision, right, where the patient has preferences and values that weigh into whether this is the right thing for them. And so there's a series of projects that we're doing that's looking at that, trying to understand all different aspects of cost communication. And right now we're finishing up a trial that is looking at the impact of actually providing patient-specific cost estimates at the time of encounter to patients and clinicians with heart failure with reduced ejection fraction. We're recording those visits and looking at how that changes both what decisions are made and as well as the nature of discussion about these novel medicines.
That is very interesting. I wonder about the mechanics of what you just said. When you record these conversations, yeah. What do you do with the conversations to get your data?
You mean what do I do to analyze them, or how do we set it up to get the data?
Both.
Yeah. So we're doing this at sites that are at Emory and at University of Colorado. So we have basically 6 sites within 2 institutions. Clinicians and patients do have to agree to be recorded beforehand. So we only approach patients of clinicians who have agreed to be recorded. And essentially what we do, when a patient comes in, just the mechanics, when someone comes in to an encounter, we remind them they agreed to be to be in the study, and we give them their sheet with either with or without the cost information, and the clinician gets the same sheet, on the chart. And then our coordinator puts the recorder in the room and they say, we're leaving this here, just, forget about it. And then after they leave the room, we come get it. So that's mechanically how we do that. And it's been pretty well shown that people pretty quickly forget about recorder. I mean, when you listen to these, there's sometimes, especially as if it's the first time or two that a clinician has had that, to say, oh yeah, that recorder's over there, something like that. But pretty quickly the sort of fact of being observed, I think, sort of gets lost. And that's been shown, in a number of studies that it doesn't really contaminate things. Then in terms of the analysis of that, we sort of cut out all we cut out the extraneous stuff that isn't about the encounter, and then we have it transcribed, and then we're in the process right now of starting. It's really a text-based analysis that we do, where we develop in qualitative research. You talk about a code book, but you develop codes which describe particular types of things that you see, and you code it using a software program that's basically like a fancy highlighter. And you capture all the instances of different kinds of themes, and the analysis is all about looking at whether or not, for this, it's ultimately kind of a quantitative focus in the beginning for the primary aim of looking whether, at the impact of this intervention on whether decisions were made in a cost-sensitive way, where people actually talked about the cost of the decisions they were making. We have lots of sort of subsequent coding that we'll be doing, looking at how benefits are framed, how costs are, more substantively, how costs are actually discussed. Do people just say this is what it's going to cost, or do they actually engage in a discussion about what the value is or what the cost means for the patient?
So from the benefits, you mean the health benefits? The
health benefits of the drug, yeah.
And these conversations are going on. There are conversations in provider offices about cost of drugs.
Yeah, they often happen. I mean, so we're in the process of
not in my clinic, right?
Yeah, so we're analyzing our own data now. But if you look at the other studies have been done sort of leading up to this, not necessarily in the heart failure context, cost is raised in some form or another in an appreciable number of encounters, depending on the context. Anywhere from sort of 30 to 50% of encounters have something to do with that. Now, sometimes it's really bad discussions, right? It might be, here's a new medicine, you have insurance, I'm sure that'll cover it. Well, but their copay may be huge, right? So that's a bad example where cost is being raised, but it's not being raised in a way that actually helps the patient make a decision. Sometimes it'll, but one of the big gaps, and what we're really trying to address, is often, clinicians have no idea what that patient's cost is going to be. You could see 5 patients, not necessarily in the VA system, but take yourself out of the VA system, you could see 5 patients, and if you're looking at sacubitril valsartan, right, the cost of the patient could be anywhere from $5 a month to $550 a month. And those are very different propositions.
Depending on your insurance.
Yeah, depending on insurance. You look at the Part D population is actually a really interesting population because, there are, for people who have commercial insurance, there are drug assistance programs, the sort of coupon card stuff that can standardize things a little bit, but because of, for probably appropriate reasons, people who have Medicare Part D coverage are not eligible for those. And so their copays vary enormously from one program to another. So if you have a Part D patient, they're not going to get sort of a pharmaceutical assistance, and you see copays anywhere from, for that drug, anywhere from $5 to $300 or $400. So in a population that has typically fixed income.
And can you talk a little bit about the psychology of accepting that? or not accepting that? Because I've heard you talk about this as well.
Of accepting or not accepting the costs?
Well, sort of what? Yes,
Yeah.
So you have some discussion about financial toxicity, right, between the provider and the patient, and then, but then there's the reception and output from that from the patient.
Yeah. So I would say our first. Let's separate these a little bit. Our first trial is really just looking at what happens when you give people the amount. And, that is not instructions for how to talk about cost, right? That's sort of subsequent work is going to have to deal with that. We have, though, done a lot of work with us, mostly with patients, my colleagues, some with physicians, about, how do you approach these sorts of things? And you see some really kind of alarming trend. So some of it is what you might expect, right? We've done kind of experimental studies where we've shown that people seem to be cost sensitive. So you take that drug and you show them the benefits. There's a radical difference in number of people who are willing to take it at $5 a month versus $100 a month. That's not too surprising, but we've done some other kind of experiments looking at, if you ask them to think about their finances first, does that matter? So all these different kind of framing things, and we've seen some interesting effects of that. But you also have patients that just treat a 3% absolute reduction in mortality of 2 years very differently. Some people would say, like, that's life or death. I'll do anything. Other people say, well, that looks like, that didn't look like a big deal. You show them a picture of these two pictographs, with a bunch of like smiley faces and then, three frowny faces. And you're like, that's not, most of the people are still smiling, right? They're still alive. Like that's not a big deal. Like Andy Smith likes to tell a story, and we've seen people a lot like this of some guy that he was taking care of, that he prescribed a medicine that was going to cost him $50 a month, and this guy, was a relatively high power guy with a lot of money. And he's like, $50 a month, that doesn't seem like a good buy. And he's like, you spent more than that on dinner last night, and this like has an impact on your life. Like that's crazy. So we're very interested in, and with one of our fellows, Birji Rao, who we just wrote a paper that is a little provocative, but saying, look, we have to be ready to nudge people the right way, right? When someone has plenty of means and they say, look, that doesn't look like a meaningful difference, sometimes they need to get pushed and say, like, what are you expecting, right? Like, that's 3 people who are alive, who wouldn't be alive, It's up to you as to whether you want to take it, but let's not just dismiss it because the pictures look the same. Like, let's think about what this really means. Sometimes you have the other problem, which is that, it's a really interesting psychology where sometimes people see a price and they think, well, whatever's more expensive must be better. I want that one. Like I give a talk on this where I talk about the fact that one time I was like working on the talk and my kid came in and, Henry's like, well, what are you going to talk about, Dad? And I was like, well, it's about, medicines that are more or less expensive and how you work with patients to make decisions about what's right for them. And he's like, well, whatever's more expensive must be better. Just take that one. Like, yeah, so that's a problem too. And there's good data to show that happens sometimes.
Yeah. I mean, I hear stories about people who, they have a discussion with their provider, they get prescribed drugs, and then the bill comes and they're what the heck's going on here? That seems to be fairly common, actually.
It's really common, and it's bad and that's what we're trying to derail with this trial, right? So what happens is they get to the pharmacy, right? You leave your doctor's office, you show up at the pharmacy, and they're like, that's $500. And now you're standing in front of a pharmacist who is not in a position to know whether because they don't know your history, they don't know everything about you. You can't then like call your doctor and say, hey, wait, you tell me this is going to be $500. I can't afford that, or that's a big hit for me. What should we do instead? And so you can end up with situations where people just never started medicine. You can end up with situations where people, spend a lot of money on something that isn't that helpful for them. It's really, we disaggregate the sort of price disclosure and decision making, and the whole goal of our work is to try to bring those together. And at least then we have to figure out how to actually frame it appropriately.
So the goal of your research would be to improve healthcare delivery through better communication about financial toxicity.
Yeah, I think.
Am I using that word too?
No, I think that's right. I think it's not just financial toxicity, because financial toxicity are actually harmful effects that come from finances. But I think really what I think we're saying the same thing, but our goal is to try to effectively integrate cost into decision making so that people and their doctors can make decisions that are right for them. But it's hard.
Yeah.
For psychological reasons.
Changing a lot of practice patterns that are already well established.
Yep. And some docs are really resistant to this idea of like putting a price on life.
Yeah.
I mean, when you look at the ways that cost discussions go wrong, there's certainly doctors that feel like they shouldn't have to do that, but that's the reality for their patients, and we have to acknowledge what people are. We don't get to say you have to do what's right for your health, no matter what the expense to you. That's not right. So
$5 ACE inhibitor versus a $500 ARNI,
and you can't necessarily make assumptions about what people are willing to pay.
What does shared decision making mean?
It's like this term
in this context that you're talking about, I guess.
It's like a term that I love and hate at the same time. It's the biggest mom and apple pie concept. You can't argue with it, right? Of course you're supposed to, like, the doctor has a role, the patient has a role, you're supposed to share the decision rights. So I mean the concept is like unassailable. The concept is that, the patient brings certain kinds of things to the table, the doctor brings medical expertise to the table, and there should be a process that helps those to meet so that you come up with the right decision for the right patient. I mean, that's what shared decision making really is at its core. What's interesting is it's appropriate that that's what we should strive for, but operationalizing it is just really, really hard. And I think there's some people that take it to extremes and say that doctors should never offer recommendations, or just like informed consent and autonomy, you never challenge people who are making different decisions. And I think that's wrong, right? I think a good shared decision-making process between a clinician and a patient can sometimes involve pushing back on decisions that they want to make sure they really understand what they're doing and why, asking questions to really understand what they care about. And it's hard and it takes time. And one of the things that we've really tried to push on is that it's not just one of those things that's a value add if you try to do. If you do it poorly, you can really go wrong. And that's why I think decision-making interventions have to be subjected to the same kinds of evidence that other kinds of tools are. And we've seen that, we do some work in the electrophysiology space in collaboration with Faisal Merchant, where for defibrillators, CMS just one day required a shared decision-making process using a decision aid, which is just a fancy sheet of information that's carefully created, but they required that in order to pay for defibrillators for patients covered by Medicare. But ironically, like NHLBI had just funded a trial to look at whether decision aids make any difference in these decisions. And, a separate federal funding agency is trying to figure out how we measure shared decision making. So something was actually mandated by policy with, at that time, no evidence of what impact it had on decisions. And it could plausibly result in bad decisions. I don't think in that particular case it was likely to really result in bad decisions, but we need to know what happens if we're going to require that people go through certain kinds of processes.
So your work would inform that before that policy would be implemented.
Yeah. I mean, what we're doing, price transparency is a great example, right? There have been policy efforts to try to expand price transparency. One of the problems is price transparency is really hard. Like at one point they were recommending just putting the list price of drugs, the wholesale acquisition cost of drugs, on direct-to-consumer advertising. Well, that's a meaningless number, right? We don't. If you just said at the end of an ad for Entresto, when after they tell you that it can kill you in all these different ways at the end of the TV ad, they say, oh yeah, and the wholesale acquisition price is $650 a month. Like that is the most useless piece of information you can imagine. Some people are like, I could never afford that, even if it only cost them $5 a month. Other people say, I got to get me some of that because that's expensive, right? So I mean, it just is and it doesn't apply to most people. So there's a lot of complexities.
Yeah, and I'm seeing a connection here between this shared decision making as far as explaining medicines and what you should be on and physician recommendations, and the consent process. I mean, those are related.
Yeah. Yeah, they're related. I mean, it's a lot of the same kind of.
It's a different kind of consent.
That's exactly right. What you're asking, what you're deciding about is different, but you're doing it with the same group of people, right? They're both patients.
Yeah, and you're getting the same psychology from that side, I guess.
Yeah. And one of the things we're interested in that space is, I mean, you've written consent forms before. You know that there's a section that's supposed to be about benefits, and usually there are commonly requirements that basically say you may not benefit from this. That's often what we say.
Yes.
Because God forbid people think they're going to benefit from this. Yet when you talk to patients about, like, especially in clinical trials.
Disclaimer here.
Yeah, especially in clinical trials, they're like, well, you need to tell me, like, why are you doing this study? Why is it important? And how might I benefit? You need to tell me the risk too. Like, it's not to say that, but you should tell me that. Right? And we had patients that had been through consent processes for stroke trials. They look at this consent form and it doesn't say we're doing this study because we think that this medicine might reduce the size of stroke. Like, we don't know for sure. That's why we're doing the study. Yeah. But it's interesting that there's been this perception that you can't tell people the benefits because they're going to have this, like, they're going to have what's called therapeutic misconception or misestimation. And they're going to think they're signing up for a treatment that's shown to be beneficial. Well, patients are a little more sophisticated than that. We actually have to, like, they will tell you, you're asking me to make an informed decision, but the piece of paper doesn't even tell me, like,
it just tells you what might be bad for you. What might?
How can I get hurt?
Yeah,
and it doesn't say why the study's important. And they want to know, how can I get hurt? How might I benefit? And why does this matter?
So this relates back to the stuff you're doing with P-Care, I guess, or the stroke patients. Okay, as we are in our final stretch here of this research ride, you're from Augusta, Georgia.
I am.
Son of a judge.
Yeah.
Maybe that was shaped part of your ethical interest in ethics? Yeah.
No, I remember at one point my dad being like, my dad's definitely a big role model for me and someone that, I've looked up to in so many ways, but he is, he became a judge after I was in college, but I remember one time having to introduce him and saying, he drove me crazy because he was like the most fair person in the world. And as a kid, I didn't always want him to be fair. I wanted to be, but certainly now I respect that more and more and more. But yeah, I think, my career is sort of a product of a lot of influences I've had from my family. Certainly my dad is a lawyer and judge. My mom was a teacher.
Yeah.
And I have a grandfather who was a priest, a grandfather who was a small town family practice doc, and two grandmothers who were teachers. And I often joke that, a academic bioethicist is sort of a conglomeration of all those influences. And I really do think that's true. So, yeah.
And the importance of family, is that important in what you like to do now for extracurricular activity or recreational activity?
Yeah. I think big picture importance of family. My wife's from Atlanta and I'm from Augusta, so it was important for us to be, we're here, we're close to our parents, and family's a big part of our lives. In terms of our immediate family, that has a lot to do with what I do. I've got 3 boys. So they're, we have 9, 13, and 15. And I spend a lot of time, some coaching, but a lot of time at basketball games in particular. And, the kids' activities certainly structure a lot of.
You played basketball growing up?
I did. I played high school basketball.
That was your sport?
I went to a small school and I played soccer, basketball, and tennis. Tennis was really what I did a lot growing up, and then in high school I sort of moved more toward basketball was what I enjoyed the most. My son likes to remind me that I went to a school where I was a 6'2" center, and he's about that height now, and he's a shooting guard, and basketball was smaller. But yeah.
And you are an avid cyclist.
I am. I love to ride.
How did you get into that?
If there's anything that I always did, it was probably riding my bike. I mean, when I was a kid, that was all I wanted to do. I rode a bike early, gave myself a good concussion when I was 4 because I was riding a bike that was too big, and we didn't really have helmets back then. At least nobody wore them. And when I was, in elementary school and whatnot, my life was my BMX bike and, jumping it off whatever I could find to jump off. And, so I've always really liked to ride. And for some time in college, I got really into mountain biking. And then as mountain biking got logistically more challenging and took more time, I started, spending more time road biking. As family life and work life has become more challenging, I spend more of my biking life not moving on an indoor bike.
Yeah, I've heard about that.
Yeah. So I do, but it's still really
We're talking about Peloton.
I do. Yeah, I'm a Peloton fan.
What is your handle? Your Peloton handle? Am I allowed to ask that?
Silver Sonic.
Silver Sonic.
Silver Sonic. Yeah.
Yeah, I heard someone say that they can't keep up with you on the leaderboard.
I'm at that bad stage though where I don't know if you do the Peloton, but if you really get into it, you're supposed to do these FTP tests and whatnot to kind of gauge your level of exertion. And my last one was about a year and a half ago, and I think I may have hit a spot where, without investment in significant amounts of cycling time, I will never improve my FTP, and I can't accept the fact that it's declining. So I won't test.
So who is your Peloton instructor?
I'm a Matt Wilpers guy. Matt Wilpers, Matt,
the Georgia native.
Yeah, that's right. I only do the Power Zone rides, and Matt and Dennis are my go-tos. And half the time I don't care about the music. I turn on closed captioning and I'll watch a Hawks game while I do it. Or something.
Oh, is that right?
Yeah. Depends. If I'm doing something really hard, I listen to the music and focus. But I do a lot of easier rides and watch something else.
Well, that's good to know for our listeners that they can look for the Silver Sonic on their Peloton leaderboards. Yeah. And the last thing I want to ask you about is
music.
So we're developing. I mean, you heard from the last podcast that we're developing this playlist for our research ride. We've got contributions from our previous guests on this podcast, and we're wondering what you would contribute to that playlist.
So you have to be. So I get 3 songs. Is that right?
As many as you want.
Oh, that's much better. I was struggling with that when I was walking over. I'm like, man, you've got the historical piece of what means the most to me over time. What am I listening to now? Yeah. All right, so maybe we'll go with 4 songs. All right, so
Perfect.
I grew up in Augusta, Georgia. I grew up on REM, so I have to have a little tribute to REM. I think Driver 8's my favorite song by REM.
Even though they're from Athens.
Yeah, exactly
Georgia.
Right. That's right. So I got to have a shout out to my Georgia contingent. I guess if I were really true to Augusta, it'd be more James Brown, who I love too. But we'll go with REM. I'm a big fan of The National, and maybe Mistaken for Strangers is my favorite song by The National. These days, my kids are more. My kids are influenced. I have to try to be a little contemporary, and recently a family favorite is "Unstoppable" by Sia, which I love. That's a good one if you want to do well on the bike.
Yeah,
that one will get you pumped up.
Okay.
So that's high on the list recently in terms of more pop music that I like. My kids like a lot of hip hop. I try to get them to sort of think back a little bit. I'm a big fan of "Can I Kick It" by Tribe Called Quest.
Yeah.
So maybe that's 4. If I'm the other
wide range of
it's all
music
over the
here.
place.
Very good.
And if you put a clean version of "Stir Fry" on by Migos, that's a tough one to pass.
All right. I don't think we have any.
That's a tribute to my kids. They
we don't have any rules about that on our playlist.
Well, I might.
Well, Neal, Dr. Dickert, thank you so much for joining us today on our research ride and giving us an awesome tour of your research program. It's unique and interesting, and a lot to think about as far as clinical research and how we do clinical research.
Thanks, Charlie. Thanks, Sarah.
Thanks for joining me on another great research ride. Our guest today was Dr. Neal Dickert. Producers of this podcast are Sarah McClellan and Ben Searles. Ben is also the editor of this podcast. Theme music composer is Hannah Searles. This has been your ride leader, Charlie Searles, and I will see you next time.